I think the main thing now is we have, in the US at least, right, we have 4 approved JAK inhibitors. And the question is, like, why should I be on one and maybe not another? I mean, raise your hands. Everyone's heard of JAK inhibitors, correct? Okay. So I think the question now is, like, with 4 available, you know, how do you differentiate? Is there a right one? Which one should I be on? How are they different? How are they the same? So we'll kind of go through some of their similarities and some of their differences. And I think there are a lot of similarities, but there are some key distinguishing factors. So, you know, first off, just to show that I do know some science, we're going to show a figure. Essentially, when you're talking about JAK-STAT activation, you know, this is really a signaling kind of mechanism. So it's like a membrane to nucleus signaling mechanism that basically allows cells to kind of transcribe certain genes, express certain genes, and perform different functions. And so it starts with a signal that comes and sticks to a receptor that's on the outside of the cell. That conveys and propagates a signal that goes down to the nucleus and says, make certain genes or express certain genes to make certain proteins to do what you want them to do. And so we're going to be talking about this JAK-STAT activation signaling within blood cells, right? Specifically within stem cells a lot, but also within blood cells. This JAK-STAT activation, or this JAK-STAT signaling mechanism, is important in other cells too, and has been implicated in a lot of different diseases: Parkinson's disease, hair loss, alopecia, different autoimmune diseases, right? But that's when it's happening usually in other cells, or activation is going on in other cells. But here, this is really a key critical kind of pathway for if you want to make red blood cells, if you want to make white blood cells, if you want to make platelets. You're going to have different cytokines or ligands, as we call them, those signalings that are going to come down and stick into a receptor. So, for example, all right, either you are on the kind of old Tour de France teams and you're biking and you'd like to make more red blood cells because, you know, that's going to make you ride a little farther, a little faster. Okay, we call it doping. You're going to give yourself some Procrit or some EPO, right? And when you give yourself EPO, that signal is going to go down to a receptor, the EPO receptor, going to lock in there, and it's going to basically propagate a signal, which these JAK proteins are a part of. These JAK2 proteins are going to dimerize. They're going to come together and kind of send that signal down, activate these STATs, which are kind of you know, other signaling molecules along the way. They're going to go into the nucleus, say, hey, let's make some more red blood cells. You're going to make some more red blood cells. You're going to have better oxygen carrying capacity. You're going to ride your bike a little bit further. You're going to win a lot of Tour de France's. It's going to come out later that you did that. It's going to ruin things for a lot of people. All right. Normally, EPO is made in the kidney, and you do that when you need to make more red blood cells, and so you make EPO in the kidney. It goes down and kind of goes through the same signaling cascade, and it makes more red blood cells, which is why people who have chronic kidney disease or are on dialysis, they get EPO, right? They get Procrit. That's one of the reasons we give those folks Procrit, is because they don't make enough of that on their own. All right. So the same thing happens if you need to make white blood cells, if you have an infection, except there you make GCSF, largely in endothelial cells or blood vessel cells. Blood vessel cells are going to be the one that knows about a bloodstream infection probably the quickest, right? And so you make GCSF, that goes down to a protein CSF3R, or the GCSF receptor, and that's going to go down and say make more white blood cells. Same thing with platelets. You make a protein called thrombopoietin in the liver. That's going to go down and connect to the thrombopoietin receptor, which is encoded by a gene called MIPL, right? And then it's going to say make more platelets. Okay, so that's the JAK-STAT pathway, and it's largely implicated in these diseases. Now, this figure shows that there's probably a lot of different ways we could target the JAK-STAT pathway. I mean, we could, create cytokines to go after the ligand. We could make things that attack, thrombopoietin or attack EPO. We could make antibodies that attach to the receptors on the outside, right, and target that. We're actually looking at that with targeted CALR targeted antibodies. We could go in and create STAT antibodies or things like that, but really what we have now is we're targeting JAKs, right? We have these 4 JAK inhibitors that largely are going after the same target. So that's one of the similarities, right? These are all kind of acting in the same way. In the future, I think we'll see other ways to target the JAK-STAT pathway, and as we said, we have clinical trials ongoing looking at monoclonal antibodies that are targeting the receptor itself in the terms of these CALR monoclonal antibodies. All right, so these are our 4 JAK inhibitors: ruxolitinib, fedratinib, Pacritinib, and Momelotinib. So kind of a quick table to show their similarities and differences. On this, you can see different years of approval. Obviously, Rux predates the other approvals by 8 years. And then we had this kind of proliferation of approvals starting in 2019. From a target standpoint, everyone, all these different JAK inhibitors inhibit JAK2, but then they have some other targets, right? We have JAK1 inhibition with ruxolitinib and momelotinib. Pacritinib is very preferential towards JAK2, doesn't really hit JAK1. Fedratinib hits a little bit of JAK1, but not that much. Do we really understand the relevance of all that? Not necessarily. I think we have a lot of hypotheses of why they may be relevant. It may be why we see more non-melanoma skin cancers in patients on ruxolitinib. It may be why there's a little bit more immune dysfunction, but not necessarily, right? We don't know that conclusively. But some of these targets do matter from a toxicity standpoint. So if you look at FLT3, fedratinib and pacritinib both inhibit FLT3. This is a relevant molecule for people that have a specific type of acute myeloid leukemia. But it turns out that when you inhibit FLT3, you tend to cause more GI side effects, right? So these agents tend to have more GI toxicity. And then I think the one other target I'd mention is this ACVR1. So the ACVR1 is involved in hepcidin and iron regulation and chronic inflammation. But the kind of take-home point is if you inhibit ACVR1, it may make iron more available to the bone marrow. It may make you allowed to make red blood cells a little bit better. And so pacritinib and momelotinib inhibit ACVR1, and both of those agents have kind of been associated with causing less anemia, maybe helping the red blood cell count a little bit. Tough to compare responses because a lot of times these agents have not been compared head-to-head. The trials are a little bit different. The patients enrolled are a little bit different. So even though I've put the percentages here, I mean, these are not fair comparisons. So both help. I mean, all of them help with reducing spleen size. All of them help to some degree with improving symptoms. Other than one trial where we compared two agents head-to-head, we don't really have direct comparisons. Side effect profile, we know, I mentioned the GI side effects we see with fedratinib and pacritinib. Other than that, we do know there is this kind of black box warning for encephalopathy with fedratinib based on a very small number of cases during its development. Some of that has been mitigated by going back and looking at some of the data with fedratinib where it's not clear that it was truly causing encephalopathy, but still that's something to keep in mind. And there is some data that suggests a mechanism by which this could happen. Pacritinib has, at least in the label, a concern for maybe a bleeding risk. We saw about 14% major bleeds on the PERSIST-2 trial compared to 7% in the control arm. High-risk population, as pacritinib is often used in people that have very low platelets who are already at risk for bleeding. Momelotinib, in the earlier phase of trials, we worried about peripheral neuropathy. We didn't see that as much in the late phase trial, the main one called Momentum. But whenever you see these things early, you can't forget about them because they tend to pop up in real world data later on as well. And then ruxolitinib side effects, I'd say we have a lot more long-term data with ruxolitinib, so you have a lot more long-term side effects as well, so just because we're aware of them. And so the three that I talk about with patients is you worry about weight gain, increased risk of non-melanoma skin cancers, and increased risk of shingles reactivation. Rux and fedratinib cause anemia, thrombocytopenia more so than what we see with pacritinib and momelotinib. And then, again, there's some other key differentiators there. So this is an attempt at a very complicated Venn diagram. Kind of you can see here some similarities, some differences between these agents. I would say, what do they share? They all inhibit JAK2. They all reduce spleen size. They all improve symptoms to some degree. They all cost a lot of money, right? Like that's not. People often ask, well, what about one of these other ones? Is that one cheaper? Not in my experience. In my experience, they're, if you have to ask, you can't afford it type thing. But I think that's one of the main issues that we come back to the companies with is like, these are good drugs, these are effective. We just have to figure out how to get medication to patients because the cost is unreasonable, right? And so, fortunately, there are a lot of mechanisms in place, but I will tell you what, it is the bane of our existence, just trying to make sure that patients can benefit from drugs that they should benefit from. Overall, this is kind of showing that there's a lot of similarities between these agents, but there are some key differences, and really what it comes down to is what are the distinguishing factors? And it's as simple as this. Impact on cytopenias, tolerability profile, right? I think that's the main way that these differentiate, because from an efficacy side of things, in terms of what can they do, they're very similar in what they can do. And certainly in one patient may have a better response than someone like with one JAK inhibitor compared to another, but that's difficult to say from the data. Across the board, the data shows that these are effective in reducing spleen size and symptoms. All right, so let's look about the one study that compared two JAK inhibitors head-to-head. And so this was the Simplify-1 study that compared treatment-naive patients with myelofibrosis and compared ruxolitinib versus momelotinib. Now, this was not an anemic population. This was actually a largely non-anemic population. It was really just pretty much all comers, and as long as they had splenomegaly and symptoms. And what we saw here is that both were about the same at improving spleen size based on standard metrics. And it looked like Rux was maybe a little bit better at improving symptoms. And I'll say in the real world, since we've had access to these, I would say that kind of plays out. I think Rux is probably a little bit better at symptoms than momelotinib is in kind of an all-comer population. So then Simplify-2, again, largely compared Rux to momelotinib, but it took patients that had already been on ruxolitinib. So you had patients that had been on ruxolitinib that largely had some degree of anemia, and it said, hey, we're going to switch half of you to ruxolitinib, and the other half we're going to keep you on quote-unquote best available therapy, which 89% of those folks stayed on ruxolitinib. And what we saw there is that really the spleen stayed about the same. So if you switch someone from one JAK inhibitor directly to another, you didn't see a lot of change there. And then from a symptom standpoint, it seemed like the group who switched to momelotinib felt better. Couple caveats there. These people signed up for a trial understanding that they could switch over to momelotinib. They either stayed on the agent, and they knew what they were switching to. This wasn't blinded. So they either stayed on the agent that they'd been on and were like, oh man, I didn't get onto that other one. Or they went on to a new agent and said, oh, I'm getting the new thing. That's nice. So I think that plays a lot of role when you're looking at symptoms in clinical trials. Is if you know what you're getting, it's going to impact, how you feel. And so when we look at symptom responses, it's very, very critical that these are blinded studies. And so this will come up in the next trial, which is the Momentum trial. So this was momelotinib's really registrational trial. And so when you think about kind of the development of this agent, you had Simplify-1. Okay, head-to-head. Momelotinib looks like it's as good as Rux in spleen symptoms, but maybe not, or in spleen-related metrics, but maybe not as good as symptoms. But man, it seemed to help a little bit with anemia, right? So it seems like it might be good there. So, okay, well then we looked at in the second line in patients that got anemic on Rux, and man, they felt better, right? But didn't really help a ton with their spleen, compared to Rux. And so let's design a trial and take patients who've been on Rux before, who are anemic, who have a big spleen, who have symptoms, and compare them to something that we would use for people that have anemia, and that was danazol, right? Because again, the primary endpoint of this study was symptom improvement. So you can't have it compared to placebo or best available therapy, because if you have it compared to best available therapy, you're getting the study drug or your physician's deciding something else. So it has to be a standard comparison. That way you can get it blinded, right? You're taking something, you're not sure what it is, right? And then when you talk about your symptoms, you're not jaded by the fact that you're on a study drug or you're not. And at the end of this study, what it showed is momelotinib was better than danazol at improving spleen sizes and symptoms, and actually helped more with anemia. So it showed exactly what it had showed previously in trials, but it did so in a way that allowed for it to get approved. When you look at just the impact of anemia, you can see on the left, this is a bit of a hard graph, so I'll kind of orient you. So basically the light blue box and the light pink bar, those are kind of how many patients were requiring transfusion, or how many patients were not requiring any transfusions at baseline. So in the momelotinib arm, 13% of patients were not requiring any transfusions. In the danazol arm, 15%, about the same at the start. At week 24, now that went up to 30% with momelotinib compared to just 20% with danazol. So that's why we think this helps some with being able to avoid continued need for transfusions. And danazol actually is an active comparator, right? It helps with anemia. So this isn't something that is completely inert by any means. But to really get a sense for the difference between Rux and momelotinib, you go back to this curve from Simplify-1, which was looking at patients that were randomized to momelotinib or ruxolitinib. Right, so momelotinib is going to be that top curve that stays relatively stable around 11. I said this is a largely non-anemic population that was enrolled in the study. Average hemoglobin was really between 10 and 11, and they kind of stayed there, right? That was what happened. With ruxolitinib, those patients dropped within the first 2 to 4 months, which is what we see in practice. When we start ruxolitinib, we know you're going to get this kind of drop in the hemoglobin, and then it's going to gradually improve by weeks, by months 4 to 6, which it does a little bit there. But then what's interesting about this study is at week 24, everyone went back on to momelotinib. So then you see that curve jump back up, right? And so people switch back onto momelotinib, and the hemoglobin jumps back up. And there you see the difference between the two as far as what they do in terms of anemia. And in practice, that's what we see. In patients who are switching from Rux to momelotinib, you have them on Rux and they're anemic. We switch them to momelotinib, that ticks up a little bit. Is that momelotinib improving the hemoglobin? Or is that coming off of ruxolitinib that allows the hemoglobin to go up and momelotinib doesn't hurt it? So, I mean, at the end of the day, I don't know if there's a huge difference there, because what you're trying to do is accomplish the benefits of being on a JAK inhibitor while not hurting the hemoglobin, which momelotinib can do. So takeaways from this, I would say, really both Rux and momelotinib helped a lot of people improve the size of their spleens and feel better than they did before. Patients who volunteered, again, you're volunteering for a clinical trial, to switch from Rux to momelotinib tended to feel better than if they stayed on ruxolitinib. In anemic patients who had spleen symptoms, had previously been on Rux, momelotinib was able to help improve spleen size, symptoms, and transfusion rates better than an agent that we really just use to help anemia. And in comparison to ruxolitinib, momelotinib tends to maintain stable hemoglobin while achieving symptom and spleen benefits. All right, so let's talk about fedratinib. And so this is an agent that kind of gets lost in the mix, right? So Rux got approved, we had fedratinib, but fedratinib, was hard to find a place where we'd use that over Rux. And then you had the rapid approval of Pacritinib and momelotinib that had these kind of, clear niches as far as low platelets or anemia. And fedratinib kind of got lost in the mix. But if you go back, I would say really where fedratinib has the best data is second line data, right? So after ruxolitinib and someone who still has a big spleen, fedratinib is a very effective agent. The JAKarta-2 study was really the first study that looked at patients that were exposed to ruxolitinib that still had disease or still had big spleens, and they went on fedratinib and had really quite marked responses. And if you asked me if I thought of all the JAK inhibitors, which one I thought was the strongest at reducing spleen size, I would say fedratinib probably is. Now, there's not a lot of data to support that, but I would say that just when you look at what's out there, fedratinib seems to be the strongest JAK2 inhibitor. Now, there's other things that limit its continued use. I don't know if it's the best symptom agent, but I would say just in terms of spleen volume reduction, it seems to be the strongest. From a side effect profile, though, we have more problems with fedratinib than we may have with ruxolitinib because it does hit FLT3, and we saw very high rates of GI toxicity in the JAKarta trial and the JAKarta-2 study. So here, well, you can't see it, so I can say whatever I want. So here you see rates of diarrhea, 66%, rates of vomiting, 42%, nausea, 64%, constipation, 10%. All right, so that's over 2/3 of patients who are having GI side effects to some degree on this agent. Now, you could nullify that a little bit where you look at placebo and you can see the rates are like 15, 16%. Okay, so there's some degree of that. So subtract it, right, and say, okay, now it's going to be about half of patients that are going to have new treatment-related side effects from this from a GI standpoint. What I would say, though, is they didn't do anything to prophylax against that, right? They didn't give people antidiarrheals. They didn't give people anti-nausea medications. There wasn't as focused attention on reducing those side effects in this study. And so the kind of single-arm phase 3B study, what we call the Freedom or Freedom 2 studies, have done that, right? They've said, hey, we need to really think about how we can get this effectively to patients. And they've said, we're going to put people on antiemetic therapy when they start the medication. We're going to have them have PRN, antidiarrheals. In case diarrhea pops up, they can take it that night. They're not having to call their physician and say, oh, man, this has been going on for 3 or 4 days, right? And what we see is if you do that, you reduce the rates of these GI side effects being reported by over half. Right, and so I would say that in practice, with aggressive management of this, it's not a non-starter. Like we could definitely use these agents. We've used these agents very successfully in practice, and I think with education and preemptive anti-emetic and diarrheal therapy, these can be quite effective things. So this shouldn't be a reason never to use something, although it's definitely a reason where if you have multiple options, you may prefer the one that's not gonna, you may not run into those side effects. So yeah, so if you take someone off ruxolitinib for a few weeks and then restart them on fedratinib, they're likely to have a nice reduction in their spleen size. So what I didn't mention is a lot of these studies. So one of the nuances of the studies is that on a clinical trial, which is not something we do in practice, when you take someone off of ruxolitinib and you're running a study to go on fedratinib, they'll say, okay, now you have to be off drug for 2 weeks, okay, and then we're going to take a picture of your spleen right before we go on the study. All right, so what that does is you take someone off of a drug that was probably still doing something for their spleen, you take them off for 2 weeks, spleen starts to grow back, right? You take a picture of it, you start them on a new drug, spleen shrinks down again. All right, in practice, we would not do that. The one study that didn't do that was that SIMPLIFY-2 study, and we didn't see any spleen responses there. Because in reality, as I said, these JAK inhibitors all help with spleen. And so, if you keep someone from one to the other, it's going to probably stay around the same. And again, needing to be smart about prophylaxis for GI toxicity with fedratinib. So quickly, PERSIST-2, this is with Pacritinib. This enrolled a very low platelet group, so patients had to have less than 100,000 platelets when they went on this study. And again, in this patient population, it was very good at improving symptoms and spleen size. One of the comparators in this study, it was best available therapy, included ruxolitinib, but ruxolitinib had to be used on label, and for patients with the platelets counts under 100,000, that means it had to be used at like 5 milligrams twice a day, which is not a very effective dose for these patients. So Pacritinib is better than low-dose ruxolitinib in these metrics, but again, really serves a patient population that we didn't have too many options for. Also, retrospectively, it seems like it may be helpful in terms of transfusion requirements and anemia. So, unfortunately, we didn't look at anemia benefit prospectively in the PERSIST-2 study. This was something that we went back retrospectively and looked at some of this data to say, okay, well, how many transfusions were these patients requiring before and after therapy? And it tends to be that Pacritinib may actually not just be something we can use safely in low platelets, it actually may help with anemia to some degree as well. And goes back to that target of the ACVR1 inhibition that's very similar to Momelotinib. But unfortunately, similar to fedratinib, Pacritinib did have high rates of GI side effects. Again, because you can't see from there, orienting diarrhea 67%, nausea 38%, vomiting 21%. So again, high rates where you're talking about 50, 60% of these patients are experiencing some degree of GI side effects. Then you look at best available therapy, that was also seen in 15% or so. So again, subtracting that, about half of patients having new GI side effects from this agent. So takeaways from Pacritinib in patients with low platelets who can't be on effective doses of ruxolitinib, Pacritinib can be fully dosed and get better responses than suboptimally dosed Rux or alternative strategies. Pacritinib may help a little bit with anemia, but you need to watch out for GI toxicity, and just like we talked about with fedratinib, prophylax and get ahead of it. So in closing, I would say some important thoughts and considerations. So all JAK inhibitors can reduce spleen size and improve symptoms. It's really tough to say if there's a quote-unquote best JAK inhibitor. It's about finding the best JAK inhibitor for the patient. Everyone has different issues. I mean, I think if patients who have ongoing Crohn's disease, I'm going to really stick away from some of these GI ones, right? And other patients, I think that sometimes we'd reach for fedratinib based on some of the data. Best really can't be generalized to all MF patients. Toxicity is a concern, but as Ruben talked about earlier, a toxicity that will go away is not a toxicity that means that you need to never use an agent, right? Because you shouldn't, the fear of a potential toxicity is not a toxicity yet, right? So we need to be educating patients, talking through what would happen if that toxicity emerged, how we're going to plan on managing it, and certainly deal with it when it comes around, if it comes around. Dose matters, right? So that's a big thing we see with ruxolitinib, is it could be dosed all over the place. A good dose of ruxolitinib isn't a very effective. A very low dose doesn't seem to be too effective. And so if you're in a situation with low counts where you can only be on low dose Rux, an alternative agent may be an improvement. Long-term experience means more info on long-term outcomes, but also more info on long-term safety. So we know about long-term safety profile with Rux. We unfortunately just don't have a lot of data on long-term safety profiles with the others because they were only recently approved. So these are still, for the most part, symptomatic drugs. Quality of life should be the goal. Certainly we have survival data with ruxolitinib, which I think is very encouraging, but that survival data probably comes from an improvement in quality of life. And then we have to go back to the fact that quality of life is something you guys tell us, right? We're not going to tell you if you're feeling better. You guys tell us if you're feeling better. Okay, we may remind you of how you felt before, because sometimes you forget and you say, remember you came in here feeling terrible, right? But again, you tell us kind of how you're tolerating things, how things are going, how things are impacting your life, and then we can help to make the right decision. All right, that's it.
Thank you so very much. questions for Dr. Kuykendall? All right. Okay. Sorry.
Hi, I have a question about the side effect of ruxolitinib. So, is a skin lesion one of the side effects? And I saw some few research talk about the skin cancer, so I'm a little bit concerned.
Yeah, so it sounds like the question you're asking was really based on ruxolitinib and the risk of kind of skin reaction, the right skin lesion. So the big side effect from ruxolitinib we talk about is the risk of non-melanoma skin cancers, right? So we're largely talking about squamous cell cancers, basal cell cancers, and very rare, since we're talking about like Merkel cell carcinomas, these are very rare kind of neuroendocrine skin cancers. In general, what we've seen is probably around a 3- to 4-fold increased risk of non-melanoma skin cancers. Hydroxyurea is probably around 2, like 1.8 to 2-fold increased risk. The mechanism by which we see this, I think, is still debated, but there is some immune dysfunction that happens with ruxolitinib. So you're acting on the immune system. There is some T cell dysfunction, and really we rely on a robust immune system to deal with precancerous lesions of the skin. So if you imagine, I'm in Florida, right? So everyone's in the sun. You're getting sun exposure to the skin all the time. You're probably getting some DNA damage in these skin cells. You're getting these precancers. The immune system's cutting those things out as quickly as it can. If you kind of tilt that balance of immune regulation, it may allow for a few more of these to start to break the surface. Now, does it happen to everyone? No. There was one presentation at ASH maybe 4 years ago or so that seemed to be the people that developed the non-melanoma skin cancers were ones that had a history of non-melanoma skin cancers in the past. So there's probably more components to that. And we certainly have patients in our practices, right, that have a history of a few, and then they go on ruxolitinib and like, they pop up all the time. I have a classic patient who's been on ruxolitinib who seems to get a Mohs surgery every 2 or 3 months. And we've offered her to switch to every other JAK inhibitor. And she was like, over my dead body. I feel so much better on ruxolitinib. I don't mind going and getting these things cut out. I'm like, but there's other ones now. We have alternatives. She's like, absolutely not, hun. You're not going to do it. I'm like, okay. Sounds good. So I think it is something that is, and I mean, Claire Harrison recently, they published a paper that some of these skin cancers can be nasty. They can be invasive, right? They can spread. And so it's not something that we should say, oh, don't worry about it, just see a dermatologist. We need to be cognizant of it. But at the same time, it goes into this, risk benefit, right? We need to talk with patients. Okay, like this is a risk, but if you're feeling really well and you're okay with the fact that these things could get nasty, that's fine too. And so, yeah, I think it's a challenge. We just don't have data that says that like you don't have an increased risk of skin cancers with like Pacritinib, Momelotinib, and fedratinib because we don't have the same long-term data. There's mild data with Pacritinib that it doesn't seem to cause as much non-melanoma skin cancers, but I think time will tell with that one.